lots of different answers. And I think that just shows where the field is right now, that there are a lot of appropriate things that you could consider doing. So, Joel, I'm going to ask you first to tell us what you would do in this case, and just like you did before, tell us what you think about the brain metastases in particular.
Yeah, so we definitely decided earlier that we could believe the liquid biopsy and act on that. I do like the tissue testing also. Sometimes we find some surprises and provide context in EGFR mutant lung cancer, but this is exon 19 deletion, the most common classical sensitizing alteration. Historically, we would have done osimertinib monotherapy, but we've had 2 clinical trials showing superiority versus osimertinib, the FLORA2 with carbopem-osi, and the Mariposa with IV Amilas, and sub-Q just approved. So, for convenience, tolerability, things like that, I tend to go with OC plus chemo in this situation, and I'm comfortable that all of those things get into the brain pretty well. So I'd probably repeat imaging in about 6 weeks after starting that, both in the brain and the body.
And so no radiation to the brain?
Not to 25 mets.
Okay, great. Melvin, do you want to tell us your approach to this type of patient? Good performance status, common EGFR mutation. How do you think about this?
Yeah, I think as a Hawaii-based oncologist, we do see a lot of this sort of paradigm of non-smoking Asian female kind of prototypical patients. So a lot of us in the community have a lot of experience with driver mutated tumors, especially EGFR, exon 19 and 21. And so, yeah, I think the treatment paradigm has expanded. I know I've talked to David a lot about how to choose between the different combinations or maybe monotherapy. And I think I'm just going to stress the importance of looking back at the clinical scenario, how pressing it is. Is there a visceral crisis? Is there a pain crisis going on? And sometimes that'll lead us into maybe adding the chemotherapy for a response, or at least disease burden. But I think some of us are still very comfortable with single agent TKI. And we've had, really good responses and good duration of response as well. So I've used in clinical practice all of the 3 upfront options, and I think our clinical center has become very comfortable with the chemo, OSI, and even the MET EGFR combo as well.
Maybe just for fun, we'll do a vote amongst the medical oncologists and see who would give single agent OC to this patient. Remember, good performance status. But she does babysit her grandchildren, so she needs her energy. Okay, and then what about chemo? Go ahead, John.
I mean, you can start in either order, right? Like,
yeah.
I think the intention, though, would be to give combination, but whether you start the OC a week before, you don't have to do it exactly on the same
But your plan
day,
would be
right?
to give combination. Yeah, go ahead.
I mean, you have 2 studies that show a clear overall survival benefit that's clinically meaningful. It is more challenging in terms of toxicity and coming into clinic more and so forth. But that's generally our gold standard. And the case checks off a number of high risk features: brain mets, P53, a really high allele fraction on circulating tumor DNA. So I would discuss all 3, but I would, the patient seems in really good shape. I would discuss the treatment intensified options, either FLORA2 or Mariposa.
Does anybody want to vote for Mariposa? Ami laser?
I mean, I would discuss.
You would discuss. It's hard to vote when you're not having a discussion.
I lay out the option. It's a more, it's a more complicated discussion now. I mean, there's a chemo-free regimen, but the rash can be really bad. The amivantamab sub-Q, it was actually intriguing. It's easier to give than IV, and intriguing that it may be more efficacious. We don't know for sure.
Yeah, I'll show you that data in a couple
of
slides.
And then chemo OSI would they be willing to take chemo and come in every 3 weeks? So it's a more involved discussion. But I would discuss those and offer those.
And I think a lot of times that ends up coming into my realm where I'm kind of that intermediate as a provider and a nurse, where we end up discussing the toxicity profiles to have that informed decision making with the patient between the combination regimen.
I'm going to ask you about that in a couple slides when we go into the toxicity a bit more. David, did you want to make a comment?
Yeah, I just want to make a comment in that you would think from our discussion that there's no role anymore for single-agent osimertinib, and I think that's incorrect. Patients who are relatively low risk with EGFR exon 19 deletion, that's a more favorable mutation than L858R. People with that mutation who are relatively low risk, I think it's fine to give them single-agent osimertinib. We have great experience with it. Almost everybody responds, including in the brain. And when you just say everyone's going to get chemotherapy and osimertinib, you forget about what are you going to do afterwards, and you also forget about quality of life to a certain extent, because the chemo does require you to come in, you get an infusion. Some people have told me that interferes with their work schedule, and they want to be working every time. They'd rather have a pill. And then most important, none of these treatments are curative. When you say the survival curve looks better, they're not curative therapies. So what can we do that's more rational? And I'm a big fan, I'm a liquid biopsy guy, that there are studies ongoing now that several of us participate in where everybody gets started on single agent osimertinib, and after a few weeks, you get ctDNA, and if the patient has cleared the EGFR mutation, they stay on single agent. If they haven't, then they're randomized to get to stay on or to get the addition of chemotherapy. So what you're doing then is you're giving chemotherapy to the bad actors, right? And anyway, I think in the future that may pan out.
Yeah, not ready for prime time now, but in trials and maybe something
exactly.
we do. I agree. Yeah. I'm excited to hopefully have that for practice one day. Okay, so let me show you a little bit of the data that we've all been talking about, so you can see it directly. Let's see if I could see it. So these are the two frontline trials that form the basis for our discussion. So on the left is FLAURA2. This is osimertinib plus chemotherapy, and then on the right is Mariposa, which is IV amivantamab plus lazertinib. And both of these trials were only for patients with common EGFR mutations, and they both had an overall survival benefit. And those are the OS curves at the bottom. We've known for a little while that they have a PFS benefit, and then more recently, we now see that both are positive for overall survival, which is now why they get brought into the discussion of options for our patients. They also both have good activity in the brain. And so this is looking at CNS progression-free survival, and both of them seem to have benefit for patients with brain metastases. A lot of people ask me which one is better for patients with brain metastases. I don't think I know that answer. Does anybody have a preference for a regimen for patients with brain mets? No. Okay.
I think it's clear from other data that amivantamab does have CNS activity by itself, which is kind of interesting for a bispecific antibody.
I agree. But I think they both look good. I don't know that one is necessarily better, but I think they both do have benefit there. And then this is also data I wanted to show you because there was a recent approval for subcutaneous amivantamab just very recently. So this is the PALOMA-3 trial. This is looking at subcutaneous ami as opposed to IV ami plus lazertinib. This is in previously treated patients, so it's not first line, but it shows the side effect profile, and then the primary endpoint was to look at the PK as compared to IV, which it was non-inferior. But amazingly, and this is what was just mentioned earlier, it looked like there was an overall survival benefit to subcutaneous versus IV. This was exploratory, but pretty intriguing. What really decreased is the time that patients were in clinic. It was 5 minutes versus 5 hours or something like that. Pretty good difference. And then also the rate of infusion reactions. We know that's really common in patients who get IV and pretty rare in people who get subcutaneous ami. And otherwise, the toxicity, I think, seemed pretty similar. So I wanted to talk a little bit more about the toxicity with this regimen, because I think now we're using it more and more since it's approved in the front line. and it has really good data. But there are some unique toxicities, and I wanted to Ashley, you had mentioned this before. I wanted to ask you about your experience with this, and Tammy, maybe you can tell us your thoughts as well. Maybe Tammy, let's start with you, and then Ashley can chime in on what she's seen as well.
Yeah, so certainly the dermatologic toxicities and VTEs are pretty common, right? So you have to account for both of those, and then infusion reactions, pretty significant and scary for the patients on those first infusions. So to have seen those as well. So seeing this subcutaneous version that's now FDA approved is really exciting.
Yeah, I will completely agree. I will have my caveat that most of my AMI experience is in the second line. We are kind of using a little bit more chemo OC up front, and some of our OC monotherapies that got AMI later on, thanks to our collaboration with Dr. Gander. We've had a lot of dermatologic toxicity, particularly when it was used in combination with the EGFR TKI. I've had to essentially become a dermatology fellow because there's not a lot of familiarity with how to manage the toxicities from and the severity of the paronychias and the rashes. I recently had someone have really significant peripheral edema to the point where we thought he had cardiac failure because of the severity, and it was actually the amivantamab. So we're looking forward to utilizing the subcutaneous route to see if some of these AEs are improved in our patients.
If you look at this experience, I don't know that you're going to see the rash or paronychia or edema get much better. The infusion reactions for sure, but the rest probably not. What I found helpful is pausing and lowering the dose. That's probably, in my opinion, the most helpful in lots of dermatologic prophylaxis and treatment.
Is really important.
Yeah, I want to emphasize the prophylactic doxycycline from the Cocoon regimen or minocycline, and particularly doxycycline monohydrate is the preference because it irritates the stomach less, which our dermatologist taught me.
So you're using doxycycline prophylaxis. So everybody who starts AMI gets doxy?
For 12 weeks, yes.
12 weeks?
At least.
And then are you using VTE prophylaxis in the first line as well when you give?
VTE,
Yes.
of course, for 4 months, you know.
Any other prophylaxis you guys are using?
We
those
do
two?
use topicals as well. We've seen the hydrocortisone help. Important, from our prior experience with acneiform rashes that we use clindamycin. Important to utilize the lotion, not the gel formulation, because of the alcohol. And don't forget sunscreen.
You really are a dermatologist. All right.
Ceramide-based lotions and coral-friendly sunscreens, I assume. Yeah. Okay.
Okay. You have to tell me which ones those are. Okay, let's keep going. Hold on, did I skip? No. Okay. So this is what you were just referring to, that combination therapy is not appropriate for everyone for a variety of reasons, whether it's patient choice or otherwise. More drugs obviously means more side effects, whether it's amivantamab and all the things we just talked about, or chemotherapy. And then, just as you mentioned, again, some people have excellent disease control with just osimertinib for many years. And I think a really important goal is trying to figure out who those people are. There's been some work trying to understand the high-risk patients, and you can see some of the things that have been looked at here: positive ctDNA, a concomitant TP53 mutation, brain or liver metastases, et cetera. The issue is in the studies where they've looked at this, like almost 90% of patients have one of these features. So it's almost like everybody is high risk for some reason. So I think it's something that if we can figure out who can get away with single agent, that would be great. I think for people who have low burden of disease, low symptoms, and don't want the toxicity, those are the people I'm thinking about. Go ahead. Thank you. Hi, Ann. Yes.
Hey, I just wanted to underscore this. I saw a patient last week, Thursday, who has been on osimertinib for 8 years, and she has L858R, and she started out with a cranie, brain mets, laminectomy, fusions for disease in the spine. Yeah. And so she's done well for 8 years. With one gamma knife in between. And then at the same time, I saw in the same clinic a lady who had been on the Mariposa with sub-Q Copernicus trial and had to stop because of really horrific toxicity. She went through everything. After four months of VTE prophylaxis, she stopped, developed a clot the next week, and really has open sores. At this point, she's been off any therapy for 2 months and really has gone through the ringer. So, just that one clinic thinking about, I was all for high risk patients going for the overall survival benefit, but I think we have to maybe do trials and really think of how we can do better by our patients to really underscore the point that you have. How can we save the toxicity for those patients, have them come every 3 months and really have normal lives for 8 years?
It's a real challenge. I mean, it's a real challenge now because, it's great. It's what my grandfather would call a high-class problem. We've got new treatments that improve overall survival. And as Sarah really astutely said it, if you look at all the boxes of high risk, then everybody's high risk. So if everybody's high risk, then nobody's high risk. So who do you pick? I would say the pendulum has swung for me in the direction of treatment intensification overall based on the OS benefit. But yeah, there's going to be some patients who despite being high risk on paper, years later, osimertinib, 6-7 years, I would, two things. One is you're not wedded to continue pemetrexed, right? I mean, in the study, I think the maintenance median was 8 cycles or something, so you could drop it. It's probably the upfront getting it kind of early clones of resistance or something that's driving the benefit. The other thing I do like is the ctDNA. In the PFS subset analysis, if you were ctDNA negative at baseline, it wasn't clear your PFS was different, and they had a really good prognosis of a median PFS in both arms of about 33 months. So I do like that ctDNA, which is probably reflective of tumor burden. So we need better selection markers, but it's so hard when most patients will check off at least one of these boxes here.
You want to make a comment?
One of the great things about these new agents, especially ALK and some of the EGFR, is that it's allowed the people who present with CNS disease kind of a break. We got radiation oncologists going, let's see how they respond to systemic therapy. And so we've been able to hold off on that intervention and some of the toxicities related to that.
I agree.
I just wanted to add that I think we're just now finding out how to use amivantamab long term, because I have quite a few patients that have been on the drug for years. And in some of those, there seems to be, if you have to stop the drug because of skin toxicity, and you keep the patient on lazertinib, and they've had a response, and I had one patient with massive liver metastasis, complete response in the liver on AMI laser, had to stop the AMI. Months later, the patient still has no recurrence of liver metastasis. So I think there's some biologic effect. It's been reported that there is an immunotherapy-like effect of amivantamab, and I think maybe there is, because those sort of phenomena, if you stop a TKI, the disease usually comes back fairly quickly. But I've had several examples of this.
Where the benefit is persistent.
Yeah, and then you can restart at a lower dose. But what I'm saying is, I think we don't know everything about this drug yet.